Welcome you all here. To those of you who don't know the Nuffield Orthopaedic Centre, I'll tell you a little bit about it. Some of my slides. So I'm a professor of orthopaedic surgery, but I suppose I see myself really as two things. I'm an orthopaedic surgeon. I do operations to try and help people with their arthritic process, and I kind of run a research team, trying to feed the ideas that come out of the clinical problems that we see into a kind of research pipeline, which is translational. So what we're talking about is taking science and taking it to actual problems where we can perhaps change things for patients. So I suppose that I describe myself as a clinical scientist. I do spend a lot of time doing knee surgery. I run clinical trials, so we're looking at different interventions to see whether they work or not. And there's a lot of basic science research, which is taking scientific methodology, robust methodology, and applying it to some of these problems to find out better ways of doing things. And if you were to try and sort of frame how I view my specific kind of research program, it's really looking at knee osteoarthritis. That's the majority of it. And there's a kind of timeline from when you're, say, in your 30s, or perhaps even younger, to the average age of, say, joint replacement in this country is around 70. And there's a whole pile of things that can happen before then, as perhaps your joints start to wear out. And we're really trying to unpick this timeline. This is where I work, and this is where you're sort of sitting where the camera is, and that's looking out at the wards. It didn't used to be like that. It's kind of changed quite a bit. That was the Wingfield Convalescent Home. That's the first building ever on this site, founded in 1871. And an important guy called Girdleston was appointed in 1919. He's important because he's the first ever professor of orthopaedic surgery in this country. And he set up something which became known as the Wingfield Orthopaedic Hospital for the cure of cripples. And it was set up as a national scheme. It's interesting that already at this stage there's kind of national input or leadership here in Oxford in trying to change the way that orthopaedic care was delivered. And then it became, after the First World War, it became an open-air Wingfield Hospital, really driven on by the treatment of people coming back from the First World War. There was an important contribution of William Morris, Lord Nuffield, who in 1936, he founded the Oxford Medical Clinical School, now based at the John Radcliffe Hospital. And they put forward £2 million benefaction to fund 5 Nuffield professorships. And the orthopaedic professorship here was one of those 5, the first in the country, and that was Girdleston. So as the sort of years passed, there's a development. It's interesting to note the open-air kind of wards that used to exist over on the right-hand side. You can see they were treating a lot of people with tuberculosis at this stage, and access to the free air and outside, apparently sort of come rain, wind or snow. They used to wheel people out there. I see some nodding heads in the... This is where the central research block was first opened in '58. Here's the development, and clearly the real central role of research at the Nuffield Orthopaedic Centre. 60s, 70s and 80s, there's the development of the Nuffield Orthopaedic Centre as it moved into the 90s, as I first knew it, down on the bottom right. That was the edifice at the beginning of the front of the Nuffield that we're all familiar with. And it was in 2002 and 2005 that we began this rebuild, PFI, large commitment to orthopaedics. And that was the view from one of again, we're sort of standing roughly, we're looking out from where we are, and that's where we are today. And what's important is to understand this real key role in terms of orthopaedics of the Nuffield Orthopaedic Centre, which within the Nuffield Orthopaedic Centre is a strong attachment to the University of Oxford through the Nuffield Department of Orthopaedics, Rheumatology and Musculoskeletal Science. And it's now association with the Oxford University Hospitals NHS Trust, which is the umbrella organisation under which the John Radcliffe Hospital and the Nuffield Orthopaedic Centre sit. And we're very, very sort of active in research. There's a biomedical research unit really for musculoskeletal research, and particularly orthopaedics, and a biomedical research centre at the JR, looking at all forms of research across medicine. And it's interesting to note that when we bid for the biomedical research unit, and we were successful, and we've rebid twice now, the independent statistic that came out from this centre was that 25% of the highly cited papers on orthopaedics across the world are generated from this institution. So it is a real, there's a history of world-class research from this institute, and that's really what we're hoping to continue, that sort of activity. I couldn't really fit everybody on this slide, but there's a mass of people here who, and I've collaborated with all of these people, the vast majority of them here in Oxford. There's lists that go on, but you have to acknowledge the hard work of all the team. I've put David Beard up in bold up there because he works very closely with me in a lot of the stuff we do, and he's a great colleague. What it's all about, what are we trying to achieve? In terms of osteoarthritis, these are all sort of knee interventions for arthritis, and what we're really looking for is sustained reduction in pain and improved function, and across the entire treatment history of the patient. So we're trying to get away from the world where it was, you see someone on one occasion, you have an operation, and then you go away and the deal is done. It's not like that. It's about how does this affect, these diseases and interventions affect you across your whole of your lifetime. So on the left, we have a patient in their 20s who has an early cartilage defect that's being treated with autologous chondrocyte implantation. Second in from the left is someone in their late 30s having an osteotomy for osteoarthritis. Second in from the right is a patient having a partial knee replacement who's in their early 50s. And then there's a total knee replacement on the far right who's 70. And that's across the spectrum of age and disease progression. Why is it important? Well, this is some statistics about knee arthritis and the requirement for joint replacement that may occur, or the explosion of requirement which will occur perhaps over the next 10, 15 years. And you can see this exponential growth from this graph of the requirement, predicted requirement for joint replacement. So osteoarthritis is remarkably prevalent in society. Once you get to your middle years, about half the population have osteoarthritis. And beyond that, the sort of amount of work and time lost by people due to the pain and disability felt is really very marked. So it's a massive, massive problem. That's an osteoarthritic knee. Two different patients. It's both their right knee. On the left, the inside part of the joint has been completely destroyed, and on the right-hand picture now the whole joint is destroyed. And this gives you the sort of idea of how this disease process can progress. And really what you're looking at here is the destruction of the joint so that the articulating weight-bearing surfaces of the knee are rubbed down and destroyed. And so, as it were, the tread on the tyre is worn out. There are lots of other aspects to osteoarthritis, but that's probably the most well-known and typically understood manifestation of it. That's a total knee replacement, and that's the kind of standard treatment across the NHS and probably across the world for end-stage osteoarthritis. And lots of data that shows that that's highly effective. And you can get very good results, and it's really probably over 20 years become, it's marked out as one of the real successes of surgical intervention across all disease states. It's highly ranked in terms of its efficiency and what you can achieve with it. But interestingly, there are problems, and there is plenty of data, if you go and look at it, to show that not everybody gets a good outcome from total knee replacement. And perhaps this is the best graph to show you to demonstrate this. This is the national data. So this is all of the joint replacements for knees done within the United Kingdom. This is the entire data, pre-operative data and post-operative data. And what you'll see is that although there are, if you look at the Oxford knee score on the bottom, and this is a tool that was designed to measure the outcome of joint replacement, although you can see many of those patients in the darker green shade are doing very well as their Oxford knee score increases post-operation, there are quite a lot of people down the bottom end who have a poor score post-operation. So the results are not fantastic across the board. And perhaps these are highlighted particularly in young patients. So this is a graph where that Oxford knee score, and you can see in the graph on the left-hand side it says Oxford knee score. We've just plotted out the data, and this is for each is an individual patient, and this is their outcome, and it's quite far down the line in terms of their time progression at the bottom. You can see 10 out to 20 years. And the problem is that all of those patients have a poor outcome. So all of those little dots, the Oxford knee score is too low. And these patients will be unhappy and dissatisfied with the intervention. So they will still have a lot of pain, they'll have a lot of perhaps disability. So this is a real key area of interest for us, is to try and understand why is that happening. And it's probably most brought home to you is that if you work out what we call a survival figure, which says how long do these joint replacements last, at worst in these younger group of patients who put more demands on their knee, the 15-year survival can be as low as 65%. So that's a real problem. So what can you do about that? Well, there are lots of traditional ways of trying to prevent failure. So which are to do with what the implant's made of, how you put it in, how you fix it into the joints, how you define the indications, so who you decide to operate on. And perhaps you can use navigation, which are systems which can very accurately help you put it in more accurately. But there are other ways of looking at this as well, because it's not entirely certain whether any of those changes would improve your functional outcome. So I mean, let's put the implant in as well as we can, and let's make it of materials which are the best we can possibly make them. You'll still have people who will do poorly with this operation. So we need perhaps to think about it slightly differently. One way which we've tried to develop this is how you treat knee osteoarthritis on the left-hand side. Here's a total knee replacement, but there are alternatives to that. There's a high tibial osteotomy, where you're not replacing the joint. This is perhaps an operation for a younger patient, and we're exploring a little bit more about the outcome of this type of operation. You see it's increasing across the United Kingdom in terms of its frequency of use, and I think that'll be something which will grow. Particularly in this hospital, we have a long history and track record of the development and improvement of partial knee replacement. Here's an Oxford knee, which many of you will have heard of. This is a different approach from total knee replacement and can be highly successful. That's a real success story from here in Oxford. That was innovated and designed by John O'Connor and John Goodfellow, who recently passed away, but two very famous guys who worked here in Oxford as a combination of engineering and a clinician working closely together. And that's really been taken on by David Murray. And we've taken that a step further. So here are different patterns of arthritis. On the right, the arthritis is just on the outside compartment of the knee, and on the left, as you look on the right, it's behind the patella. And now we do lots of different operations. So these are two different partial replacements where we're trying to innovate to try and improve functional outcomes. So that's one area of how you might try to improve this, and that's fairly traditional kind of in terms of the research we do, trying to improve the type of implants we do. But there's a different way which we've tried to look at this, perhaps over the last 5 years particularly, in terms of looking at how we measure the outcome of joint replacements and how you might use the tools in which you use to measure outcome to try and improve the pathway for patients within, say, the delivery of joint replacement, which may be just as important as the type of implant you use, is how you manage patients through the pathway, and hopefully I'll show some of that with you. I don't know if any of you guys recognise this man. This is Lord Darcy, who it's quite some time ago now. Time passes. That's 4 years ago. In the Darcy report, this is the first time that there was a commitment through the NHS to actually measure the outcome of interventions. And that probably surprises a lot of patients that it's so recently that people have tried to measure actually what people are trying to achieve. It wasn't that they weren't interested in their outcomes, it's just there wasn't a national commitment to trying to measure it. So Darcy suggested the introduction of self-reported outcomes by patients. So what he said was, don't let the clinicians record the outcome, let the patients tell you what the outcome of their operation is. And that was a really key step in us trying to change the way that we look at the outcome. And the way he wanted to do it was the use of patient-related outcome measures. Now, any of you who've been treated at the Nuffield Orthopaedic Centre will know what these things are, because we tend to, at every 5 or 6 minutes, we'll ask you to fill out a form, which is usually a patient-related outcome measure. And these are questionnaires which are designed effectively by patients. So we ask patients the type of things which affect them, and we build questionnaires as very precise tools based on their perceptions of the problems around having osteoarthritis. They're standardized, they're very simple to use. So typically there's the Oxford knee score, hip score and shoulder score. There are 12 questions, there's 5 possible answers to each question, and they're designed to assess the outcome of joint replacement surgery. That's what they were designed for, and it was designed with a collaboration with within the University of Oxford, with the Department of Public Health, and a lot of the guys who worked here, Andy Carr, David Murray, were instrumental in working with Ray Fitzpatrick and Jill Dawson in developing these tools. And they were taken up nationally. So every patient who has a hip and knee replacement in the country will fill out a score like this before the operation and after the operation at 6 months. And it gives you a very good readout in terms of their functional outcome. So for all of these joint replacements, and there's about 150,000 a year, we collect that data preoperatively and at 6 months. So if you look at the patient pathway, I'll just give you a moment to look at this. So on the left, you're a patient, and the first thing we're going to do is monitor your symptoms. Then perhaps you get referred by your GP for joint replacement surgery. And then there's some decisions to make about whether you want to get treated or not. Then there's having the joint replacement, looking at your outcome. But further on, you might want to make sure that we follow that joint replacement to see that no problems occur. So at the present time, that's where we use PROMs. And that's the absolutely key established role. If you look at the sort of data we now generate, this graph which I've shown you before, that's the reality of that, of Darzy's intervention producing PROMs produces this sort of data. So we can now report back to people about how well or badly we do or patients do with this type of procedure. And it's proved incredibly useful in trying to benchmark us against other procedures, in trying to work out the cost effectiveness of joint replacement. Remarkably useful for that point of view. And in Oxford, we spend a lot of time writing papers and publishing on this work, trying to understand about the outcome. And here, there's papers that we've all been involved in terms of looking at the outcome of joint replacement. But there are other opportunities in using these PROMs. So it's interesting that we might use this tool based on patients' perceptions about a joint replacement, and we'll use it to measure the outcome of their joint replacement. But we don't share any of that information with patients. So it's not something that's ever been used clinically. So we don't tell a patient what their preoperative knee score is, or ask them to think about it, or ask them to judge what their outcome might be, or help them to understand what their outcome might be. So we don't use it at this far left-hand side, but we could do, because you could use the score to monitor the change in joint symptoms if you used a PROM and use people to measure it regularly. Now that's quite important when you think about this graph, because at the moment, the time when you appear and you have, say, your PROM score measured, and what we've got down is the Oxford PROM score on the left-hand side. Down the bottom is 0, that's pretty bad, and 48 at the top is absolutely fine and normal. So if you appear in the clinic at, say, we've said 10 months, and you're down there, at that point, you might easily decide to have a joint replacement. But if you came to clinic that day, you wouldn't want to have a joint replacement. But interestingly, we don't have the data about how these diseases vary over time. I would think you'd probably think that's astonishing that we don't know that. but we don't. So there's a real opportunity in which you could use this patient-based tool to measure the change in symptoms over time in a way that patients would understand, which would help them think about the decisions they're going to make. So it's potentially really valuable to understand how that might help the assessment of individuals, help defining the indication for surgery. But there's no evidence at the moment to support it because it's not valid, because it wasn't designed for that purpose. So more work needs to be done, and I'll come back to that. So what about referral for joint replacement? Well, here's another position or place where you could perhaps use PROMs in a more innovative way. So you could perhaps ask or help GPs and patients at this time when you're trying to decide about referral for surgery. So if you think about the preoperative data we have, and it's sort of interesting that it's quite normally distributed. So at the far right-hand side of that blue curve, there were some people with quite high scores who were still having knee replacement, and they still seem to do reasonably well. But it's interesting, you could try and understand if there was a threshold, a cut point for the preoperative score, which allowed you to predict whether or not a patient was going to do well or not, so that you could share that with the patient so that they could make a